Also, it is a great opportunity to introduce Dr. Andrew McCormick for his talk. He will talk about surgical decision making.
Kia ora tātou, and thank you for that introduction. And I'd just like to reiterate the comments of my colleagues when I say thank you for the honour and privilege of the invitation from the Egyptian Society of Surgeons. It's been a great couple of days already, and I've enjoyed the sights and sounds of Cairo and Alexandria to this point. So I'm going to talk about something completely different, which is surgical decision making. And to quote William Osler, who said that medicine is the science of uncertainty and the art of probability, we're going to talk a little bit about where decision making fits in terms of surgery. So my college or craft group in Australia and New Zealand is called the Royal Australasian College of Surgeons, and it has 9 core competencies for our trainees and our fellows of the college, our consultants. And one of these is judgment or clinical decision making. So when you look at that further and how that is defined by our college, it's about making informed and timely decisions regarding both the assessment, the diagnosis, the management follow-up, and also health maintenance and promotion of our patients. And that's broken down into considering options, planning ahead, and then implementing and importantly reviewing decisions that we make. So where does this fit? Well, there are multiple decision points when it comes to the patient journey. So there is the assessment of them when they are, for instance, in my clinical practice in terms of trauma, or in the emergency room in their first assessment, and then coming up with a diagnosis, what investigations or next tests that we need to perform, and then what treatments to offer, and then explaining that risk-benefit ratio to patients. Importantly, also within the operating room, the intraoperative decisions that we make, and once again within the field of trauma, how when things go wrong, how we can get ourselves out of trouble. But also post-operatively, and also in talking to patient about prognosis and determining prognosis. So really the role in surgery of decision making is around description, describing what's going on for the patient and for ourselves, explanation, explaining what the background is, what is causing this phenomenon, prescription, and then prediction, or trying to work out what's going to happen into the future. And to just get a bit theoretical, there is a whole science in decision making. And one of the key authors in this area is a guy called Kenneth Hammond, and he has developed what essentially is a unifying theory for that field of human judgment and decision making. And what he importantly says is that decision making is on a continuum. It is on a continuum from the analytical, from the bench top, to something that is completely intuitive, that we're making a gut decision. And the nature and requirements of that task, as they're perceived by us as a judge, determines on whether we use an analytical or very scientific approach or that gut intuitive approach. But for optimal performance, we need to match the decision-making technique that we use to the properties of that task. And this really brings together a whole lot of different theories about decision-making. And one of the very famous books written on decision making is this book called Thinking Fast and Slow by Nobel Prize winner Daniel Kahneman. But really he just talks about the analytical and the intuitive and misses out a few things in between. Not to disparage a Nobel Prize winner though. So that continuum of decision making and of thinking, like I say, moves from the true experiment, which is really in the realms of physics and chemistry, to what we would call controlled experiments and medical trials, and then sort of quasi-experiments with more relaxed controls, sort of social science. And then we move into things in computer modelling and decision support, and then data-based expert judgment. And this is where we start getting to the new and growing areas of artificial intelligence. But finally is that unrestricted or unsupported judgments that we make sometimes by the seat of our pants, sometimes in the operating room, and sometimes those pattern recognition judgments that we make when diagnosing someone. So as I've said, that the continuum of the tasks of the judgment that we have to make depends on the complexity of the task structure, how ambiguous it is, going back to what William Osler said about the science of uncertainty and the art of probability. Not everything that we do is a strictly if X happens then Y will occur. And then how the task presents itself, whether it's something we have to make rapidly or whether we've got time to sit down and to mull over things. So what? Why are we interested in any of this? Well, I think it is important in terms of three realms of our practice. One is teaching our junior staff, teaching our residents, those up and coming in surgery, but also to address the important area of practice variation. Why, if with a person with a given problem goes to one surgeon and then goes to a second surgeon, we'll get a different response, we'll get a different offer of treatment. Why is that? Why does our practice vary? And also importantly, quality. We try and improve the quality of surgery that we are performing, both in the operating room, but in all those decisions and areas around the operating room as well. So you might be familiar with this concept of the progression from a medical student to a professor of surgery, for instance. So moving from someone who is unconsciously incompetent, so doesn't know that they don't know, and frankly probably dangerous in the clinical field, to someone who knows they're unaware of something, so beginning to get that sense that they need to find out, need to ask questions, to someone who is competent and knows why or understands what the decision making and what steps they're going through. And finally, maybe to the professor, the one who can just say, well, this is the decision and I can't tell you why, but that's the right answer. What is available for teaching? So these are things that I'm involved with in both our college, but also with the ISS and YATSIC, which is for trauma care. So we have a course called Care of the Critically Ill Surgical Patient, so looking at those that are critically ill on the ward or in the emergency room and assessing them. In trauma, we've got ATLS, which is once again about patient assessment, but also treatment at the same time. There is something called MOSES, which is the Management of Surgical Emergencies, once again about patient assessment. From ISS or IATSIC, there's definitive surgical trauma care, or DSTC, which is not just about assessment, but also our intraoperative decision making as well. And also moving away from clinical technical skills to non-technical skills for the surgeons, what we call NOTS. So to talk a little bit more about teaching students or junior medical staff, necrotizing fasciitis is a rare diagnosis, but one that we do see. And I remember one senior clinician in our surgical department who, when presented with this LearnX score, said, if anyone rang me up in the middle of the night and said that the LearnX score was high and that they thought this patient had necrotizing fasciitis, then I'd tell them it's just a clinical diagnosis. My response to that senior clinician is, I think that's because they're in that unconsciously competent phase. They know what they know, but they don't understand how they got there. Whereas for our junior medical staff who are manning our emergency rooms, they may never have seen necrotizing fasciitis before, they may not be able to work out exactly what's going on. So tools like this can be helpful. However, there are some problems about this. This tool was developed, the LearnX score was developed in Asia, and when we tried and tested it in New Zealand, it didn't quite fit. So we were able to develop a tool called Ciari, which fits more perfectly, or fits better with our population. So these tools do have to be modified for your clinical population. So as I mentioned, there's practice variation, which is variation that can't be explained by the illness severity or patient preferences, and is really down to variation in how we as surgeons interpret the patient's symptoms and come up with investigations and treatment. But it has implications for the number of tests we do, and also the outcomes that a patient may have. So one of the classic ones is about clinical prediction rules for appendicitis, and there are a number of them out there. Alvarado is probably the most common one. So we had a look at what they were all, and once again, like I said, showed that it didn't work very well in our population. There's another one that we developed the APPEND score. Another one was triaging lower GI bleeding, so PR bleeding. Once again, we were able to develop a tool that helped in that decision making in terms of people who needed inpatient care and predicting those that were likely to have a poor outcome. And also using the old-fashioned things like the Charcot's triad, and being able to show that that this didn't perform very well in our population, and something more along the Tokyo guidelines is better. But moving on from this is about quality and measuring patient outcomes and seeing where we're doing well and where there are problems, and improving systems as a result. So we took the APPEND score, which we developed for appendicitis, and we incorporated it into a pathway for patients who presented with 7 days of right iliac fossa pain or less. And we were able to develop a guideline and a pathway for patients based on history and examination and that tool, with the use of sparingly ultrasound and CT. We were able to reduce our negative appendicectomy rate from near 20% to 9%. In the meantime, we were able to reduce the number of CTs that were being done inappropriately. So improving the quality and the resource allocation for patients moving through our emergency department with right iliac fossa pain. I'm also involved in prioritisation, which is looking at how we prioritise patients who need elective surgery in our resource-constrained system, which is present in New Zealand. And I would assume also here in Egypt, because everywhere that we find ourselves overwhelmed by the number of patients turning up who require treatment. But what about the future? So is this artificial intelligence? In general, artificial intelligence is really what is required for a machine to exhibit intelligence. And it encompasses a number of methods, but the most common that we'll use is called machine learning, and sometimes also neural networks. And it can describe anything from the development of self-driving cars to the fact that Amazon can direct advertising and target advertising to you depending on your previous clicks. But it's hard to define what artificial intelligence is, but essentially maybe it's just automation. So machine learning is all about the use of software algorithms to identify patterns in large data sets, or big data. And it's really driven the progress of healthcare in the last 5 years in the developed world. And it has pretty impressive results in clinical decision support, image recognition and systems management. An example of it is the use of the eFast in trauma, and there is now image recognition software that can help predict more accurately than us as humans to be able to spot hemoperitoneum. A disclosure, this was written by my cousin, John McCormick, who's a computer software engineer, and he wrote this back in the early 2010, And it's around 10 algorithms or computer algorithms that have really changed the future of artificial intelligence. A little bit about machine learning. We all have bias, and that bias is often implicit or ingrained in us, and that influences the way that we work with data, and we only see what we want to see. So that goes back to the pattern recognition, and sometimes we miss important things. So when that data overwhelms our capacity, really we need help from machines to overcome that bias and to analyse and interpret the reactions between that data, our patients, and the clinical decision makers, or us. However, as I've said before, there are often only probabilistic relations between data, and clinical questions often have no single right answer, and sometimes have values in them which a computer cannot make. So we have to have oversight over these. And especially when in computer software engineering and algorithms, they talk about, where they talk about things like move fast and break things. Whereas in clinical practice, we're first do no harm. So there's a different mindset, a different ethos in those groups. So as I've said, machine learning is inferences made from statistical analysis of those large data sets, but they're more like a good guess than a true correct answer. And it's really all being facilitated by the computing power that we have available to us now, and these new algorithms that are coming. Also the availability of open source software and data that is available on the internet. So machine learning is a three-step process: the data set, developing a predictive model using your algorithm, but then importantly evaluating and refining that model depending on the population that you're using it in. And there are challenges. Sometimes the data is not available. Also, it makes a difference in the incidence of the event that you're trying to predict. So if you, in machine learning, one example was for instance, in the use of FAST, was that they trained their computer based on all images that had blood in the abdomen. But when it was then applied to a variety of FAST scans, some of which didn't have blood in the abdomen, then it fell apart because there was a difference in the incidence of blood in the abdomen in the two groups. Sometimes it solves the wrong problem, and classically an algorithm that was set up to try and work out whether things with skin cancer actually predicted the use of the ruler and said things with skin cancers if a ruler was present in the picture or not. And that's because all in the training set, all the cancers had a ruler to measure the size of it in the picture they were using. Also, like I say, correlation doesn't fit causation, and we need to be aware of the bias. And also, we're very concerned about the transparency and making sure that we can understand how those decisions are made, and it's not just a black box. We need to keep clinical oversight. So in summary, surgical decision making is a core skill in surgical practice. It has implications along the entire patient journey. It has impacts on how we teach, how we practice, and the variation in how we can improve quality of our care. Machine learning may help us to reduce our cognitive bias, and I think in general, clinical decision making is worthy of closer investigation. Thank you very much for your attention.
Thank you, Mr. McCormick. Of course, it's a plenary lecture. I'm not supposed to arouse discussion, but I may allow one or two comments or questions. Are there any? Professor Ahmed.
Thank you very much for a very, very interesting lecture concerning the issue of machine learning. As a general surgeon, and cardiovascular surgeon, we usually use the MET score sodium, the CTPA, which is Charles Torco Q, just for listing our patients. The other thing is we usually use nowadays the P-Boston score and the NILA score. I mean, having said that about the appendix prediction score and the prioritizing for waiting lists. This is something very, very interesting. I mean, most of the health trusts are going to use this prioritizing thing just for the waiting list is quite piling up patients every now and then, and we don't know which one is which because first come, first go.
Yeah.
My question is the NELA score here with the artificial intelligence. I mean, the NELA score is predicting the patient's morbidity and mortality, particularly for those who are coming for the emergency laparotomy one.
Yep.
And I did the score for the elective laparotomy ones, for the colorectal ones.
Yep.
And to be honest with you, the prediction is actually nearly the same, particularly with morbidity and mortality, and how far is this patient going to be operated upon, and how much the morbidity that he's having, the morbid things that he's having for his. To repeat my question is the role of the NELA score with this artificial intelligence and the machine learning one. Because as a surgeon, we usually do it prior to go into the emergency laparotomy.
Yeah.
But with the emergency, with artificial intelligence and machine learning, they have facts, they have data, and they are using that. Would this make any difference?
So, I mean, the question is you'd have to see, but I think the important thing is that also to realise that we often make treatment decisions based on these scores, like you mentioned, the NELA score. So, by virtue of the fact we say, oh, this is a high risk, we're not going to do it, or this is low risk, we are, that affects the outcome. Because if we say it's high risk and we don't operate, they're going to die because we don't operate.
You are under the pressure from the family that can give you the consent for patients just to do that. It's just only one chance, 94%.
Yeah. Yep.
Ending up in the ITU and ending up with a ventilator and ending up at the hospital machine.
Yeah. Yeah. And so I think that realistically, when in a resource-constrained service like, I mean, we do make those hard decisions where we say, look, your NELA score is 95%, you're unlikely to, survive this. Our best way to treat you is just to make you comfortable, and good palliative care from that point of view. And, certainly I've done that in the acute setting with a NELA score that's very high.
Thank you very much. I declare this session adjourned. Thank you, Mr. McCormick. Is Christine Long here? Thank you very much.